Welcome everyone to today's webinar, Beyond the Hospital's Four Walls, Expand Patient Care While Sustaining Growth Through an Outpatient Pharmacy. I am Aaliyah Pavela with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Kelly Morrison is an industry expert on innovating pharmacy productivity and workflows in multiple care settings, including acute care, ambulatory care, and retail. As Director of Remote and Retail Pharmacy Services for Cardinal Health, she leads the nation's largest remote pharmacy services business, hospital outpatient pharmacy services, as well as central fill and community health center pharmacy businesses. Neil Thornberry began his career in 1996 as a patient care provider and occupational therapist. He joined the T.J. Sampson Community Hospital Management Team in December of 1998 as the Director of Rehabilitation Services, leading the integration of 4 independent departments into a comprehensive rehabilitation medicine program. In October 2012, he was promoted to Chief Operating Officer for T.J. Regional Health and T.J. Sampson Community Hospital. In May 2018, he assumed the role of Interim Chief Executive Officer, and in August 2018 was confirmed as the Chief Executive Officer. Dr. Virginia Roof has worked in various leadership roles within Mount Carmel Health System over the past 11 years, including Pharmacy Clinical Coordinator, Regional Manager for Clinical Practice, and most recently, she became the Pharmacy Service Line Lead, assuming the role of the Regional Pharmacy Officer. At this time, I am pleased to turn the floor over to Kelly to begin today's presentation.
Thank you, Aaliyah, and I also want to thank everyone for participating on our webinar today. Well, we'll first talk about some of the industry dynamics that are really driving the need for health systems to evaluate a retail strategy, in addition to really looking at the impact that an outpatient pharmacy can have on your health system, as well as key areas to consider and focus on to really help drive success. We'll then hear from Neil and Virginia as they take us through their specific outpatient pharmacy strategies and journey and highlight key results in the areas that they each focused on that transformed their health systems. I'd like to first begin by just stating that I think it's important to note, in the past, health systems' main focus was concentrated on the care the patient received while within the 4 walls of the hospital. However, in talking to many healthcare executives over the last few years, and with reimbursement, penalties being implemented around 30-day readmissions, new payer bundles, executives are now forced to extend their focus beyond just the 4 walls of the hospital and really try to look for strategies to provide a seamless transition to care for the patients as they re-enter the community. There's considerable industry literature indicating the correlation between good medication compliance and adherence and reduced readmissions. And in fact, if you look at a National Institute of Health paper, they reported that poor medication adherence more than doubles the likelihood of hospital readmissions. And CMS reported that 50% of patients can't even recall their discharge scripts. And of those 50%, about 70% are likely to be readmitted. As healthcare systems look at, real quick, I just realized it. There we go. Give me 1 sec. There we go. As healthcare systems evaluate approaches to improve patient adherence, many have implemented programs such as Meds to Beds, really focused on their high-risk patients to ensure those patients not only have their medications with them upon discharge, but as important, if not more important, receive pharmacist counseling and education on those meds, how to properly take the medications, and really reinforcing how medication compliance is a key driver to their overall care plan. Finally, outpatient pharmacies can also control costs for employee benefits plans, and you'll hear more about this from Neil, as reducing employer benefits costs was a priority focus when first opening their outpatient pharmacy. So as we think about areas of focus to ensure outpatient pharmacy success, I think it's really important to note that it's not a one-size-fits-all approach. It's critical that you begin your focus on areas that drive the highest impact for your health system, which can then help support additional areas as your outpatient pharmacy evolves. Some key areas we see health systems focusing on, again, are targeting those high-risk patients, especially for transitions of care, looking at making sure they have discharge counseling, as well as, sorry about that. I'm not sure why that jumped around. Sorry about that. Looking at targeting those high-risk patients, making sure they have the proper counseling to help them actually further comply with their care plans, really focusing on med adherence and NTM follow-up, post-discharge, resolving medication-related issues, and I really think integrating the outpatient pharmacy with the important members of the care teams in the hospital, including inpatient pharmacy, coordinating post-appointment care. Those really go hand in hand, again, and they're essential in order to ensure seamless transitions of care for the patient. And then finally, many health systems are also looking for new revenue sources, and we're really seeing a large focus on specialty pharmacy today, whether that's focusing on high-dollar specialty medications or even limited distribution drugs. Through Neil and Virginia's presentations, you'll learn about specific areas they focus on, and it'll become even more clear that one size does not fit all, whether it's helping patients navigate transitions of care, reducing readmissions through greater med adherence, expanding charity care in the community, or controlling employee benefit plan costs. Both health systems' focus was different, but nonetheless successful. So now I'd like to turn the presentation over to Neil to share his experiences.
Thank you, Kelly. Good afternoon, everyone. It's certainly my pleasure to be a part of this program today and to spend time with you discussing our journey at TJ Regional Health. Now, I want to first start out and share with everyone the most cherished item in my office today, and that item is my mother's mortar and pestle. I grew up in a pharmacy family. My mother and father owned a small chain of pharmacies, and I spent many hours behind the counter before they had regulations on who could be behind the counter. And I learned a couple of very important things. One, the value of relationships with people, and two, the power of good medicine. And as I share our story today about our health system and our pharmacy, I believe you'll find those values prevailing in our operations. So let me share a little bit about our independent health system, TJ Regional Health, where we're located, and an important strategy we implemented to care for our patients. And in our community, our patients really are our family, friends, and neighbors. So our hospital system is located in South Central Kentucky, Glasgow, Kentucky. And I would describe our community as a little bit of a larger town amongst a lot of smaller towns that kind of feed into our community. So we have a pretty big trading area. We have 2 hospitals. Our flagship hospital is located here in Glasgow. It's a 196-bed hospital. And then we have another hospital about 40 miles from here in Columbia, Kentucky. It's about a 47-bed hospital, and it's a feeder hospital to our flagship. Now, also located in Glasgow, a few miles from our hospital, is our outpatient health pavilion and medical office building. Again, that has approximately 50 providers in that facility and urgent care, as well as all of our outpatient services. Our health system employs approximately 1,200 team members. In our community, we're the largest employer, like many rural areas, and therefore we're really engaged in every facet of the community. Now, specific to our health system and pharmacy, we have 5 pharmacies. 3 of those pharmacies are inpatient, and 2 of those pharmacies are outpatient, which is really the focus of our conversation today. One of those outpatient pharmacies is located in the hospital, and the other one is located in our outpatient health pavilion. Now, as it relates to the people and our mission as an organization, I think everyone would tell you, really the mission of our organization is to treat every patient we have as if they're our family, and is relating to each other and our team members. We have generations of people working here at the hospital, so we really do care for one another and treat each other with a high level of respect. So that gives you a little bit of a feel for our hospital. So let's talk about how we utilize our outpatient pharmacy as one of our key growth strategies to transform from a small hospital that was really serving about 3 primary counties around Glasgow to a regional health system that currently serves 10 plus counties throughout the region. Now, anytime I talk about a strategy, what comes to mind for me is a saying by Sun Tzu, and it says, strategy without tactics is the slowest route to victory. Again, if you have a plan and no objectives, then it's going to take you a long time to accomplish that plan. And then the second part of that saying is tactics without strategy is the noise before defeat. Again, if you have a lot of objectives that you're trying to accomplish with no real direction, then you're never really going to get anywhere. So I think you've got to have a real strong strategy with exceptional tactics if you want to try to accomplish the goals. And for us, we engaged in spring of 2016 in a strong research-driven partner in Cardinal to help us accomplish this goal. So the principles of our strategy were this. One, quality. Like many hospitals, our goal with this outpatient pharmacy strategy was to decrease the readmissions. Now, the other big piece of that strategy was about increasing medication compliance and overall comprehension. Now, from a satisfaction standpoint, obviously we wanted to provide a great service, and we just looked at everyone as our customer because, again, it was patients, it was our employees, and it was, again, a lot of other stakeholders depending on the strategy that it evolved into in our outpatient pharmacies. And the founding principle for this strategy, really all of our strategies, is if you take care of the patient, then the financials will take care of themselves. Again, if you have a good product, people will continue to seek out that product. So here's what we did. First, starting in the hospital, we had an outpatient employee pharmacy that we started with, and for lack of better analogies, it was in a closet-like setting. Now, what we did is we changed locations. We moved to a strategic area in the front of our hospital, built a storefront with this outpatient pharmacy, and located it next to the emergency room. We also had good access for patients that were discharging from our hospital. They had to go by that pharmacy. We had good access for the community if they wanted to visit that outpatient pharmacy. And then we located it across from our elevators, which led to our floors, which worked well with our Meds to Beds program that we deployed in spring of 2017. So the goal with that program, Meds to Beds, was really to make sure that our patients were leaving the hospital with medication prescriptions in their hand. Now, how do we accomplish that? Is really connecting with all the stakeholders, with the ER, physicians, as well as nursing team, hospitalists, the consulting specialists, nursing, case management, discharge planners, and then also really deployed a strong marketing campaign internally. And I think the key to that success is to stay connected to all the stakeholders throughout the process through various means, multidisciplinary meetings, and just rounding on them throughout the process. And that's really helped us grow that program over time. Now, the second piece was our outpatient pharmacy and our health pavilion. And again, just as a reminder, we've got about 50 physicians, employed physicians in that health pavilion. It has an urgent care that sees approximately 30,000 visits a year. And just to get a feel, we see about 1,000 patients a day in that outpatient facility. So it's a busy facility. Now, what I can tell you is, candidly, when you open an outpatient pharmacy in a rural community with 9 other pharmacies in our town, it creates some tension with the local pharmacies, as well as with some of your employed physicians, because they have relationships with these pharmacists. So what I did is I went out and met with all the owners, and I made it very clear that our strategy was this. We did not want to take any patient away that had a relationship with the pharmacy or with a pharmacist, because that's a very intimate relationship that we want to support. But what we wanted to do is make sure those that did not have that relationship had medications in their hands and had good compliance, because, again, it's going to drive better care. I did the same thing with our employed physicians. I had to round on them regularly and reinforce the fact that our goal was not to, again, take patients from anyone, but we want to capture those patients that do not have a current pharmacy home. And then finally, much like we did with our Meds to Beds program, we had very strong marketing inside our pavilion with our employees as well as externally to the community. And then the final strategy is our 340B expansion. Again, we're a non-for-profit, so we can participate in this federal program. And what we did is first make sure that we maximized the 340B program in our 2 outpatient pharmacies first. And then once we did that, then we expanded that 340B program to other contract pharmacies throughout the region, which gave us a better footprint and good connectivity to pharmacies throughout the region. So here are our results. I apologize for this. So this is the revenue. So from the revenue for 2017 through 2019, you can see 33%. In there, you also see we had some local acknowledgement. Again, competing against 9 other pharmacies, we were just happy to be recognized, and really something that we took a lot of pride in. And as I mentioned earlier, it really validated that if you take care of your patients, people will come to you, and the financials will take care of themselves. So when we look at the year-over-year volumes, this is what this shows here. So in the blue, you see these are the numbers for the outpatient pharmacy in the pavilion. The green are for the outpatient pharmacy in the hospital, and the black numbers are the cumulative. And again, what I can tell you is one of the most interesting stories behind this is, as I mentioned earlier, we partnered with Cardinal in spring of 2016. So to think that we created a strategy, built 2 outpatient pharmacies, and deployed those in early 2017 really was impressive as it relates to efficiency and time. And again, I think it's been a great product in both of those areas. Now, the Meds to Beds program increase in prescription volumes year over year. You see that we started that program in the spring of 2017. And I wanted to share a real important story that I think every executive and every director needs to do with every program, especially a Meds to Beds program. So one day in 2017, I came down to the outpatient pharmacy in the hospital, and I asked him if I could follow the tech, because I really wanted to get my boots on and go out to where the work was being done and really see what the processes were like, see how the tech gathered the information, communicated to the family, communicated to the nurses, then came back and brought that information to the pharmacist, saw how the pharmacist, again, processed the prescription orders, and then was able to get that back to the patient. So looking at the entire process and making sure you have continual improvement of that process, I think is a very important step, because anytime you start a program like this, you're going to have bottlenecks and you're going to have opportunities. So you want to continually improve that throughout. And again, the most important piece, as I mentioned earlier, in the Meds to Beds program is just staying connected to all the stakeholders and keeping it front of mind for them. So if you ask me, what is a successful formula? I would tell you for this strategy, it was people, process, and perseverance. You have to have the right team in place, and Cardinal provided a good infrastructure of talent, resources, and expertise for us. You have to have the right leader to direct all this, because again, if you're deploying a lot of strategies, they have to be very organized, which we have, and you have to have a very strong team approach and have accountability to that culture. And we've had opportunity over the 3 years, but we continue to increase and raise the bar to that culture. Finally, from a process standpoint, I mentioned continual improvement is big. Get out there and walk the process every quarter to see how the program is evolving. And then finally, perseverance. I mentioned earlier also that round with physicians, and to drive business to your outpatient pharmacies, you have to round on the physicians that you have employed, as well as those you do not have employed but are in your market. And probably the most important element in that is being responsive to any issues that they have, because they know if you're responsive to those issues, you take care of their patients, then that gives your program integrity, and they're going to continue to refer to you. Finally, things to consider before you implement this type of strategy, I would say, is how do you view your pharmacy? Do you view your pharmacy as a cost center, or do you view your pharmacy as a revenue producer? And for us, this strategy transitioned towards looking at pharmacy as a revenue producer. The second thing is does your strategy match your mission? What's the why behind you doing this type of strategy? And can you engage your teams behind that why? And then finally, and probably most important, is do you have the resources and do you have the people for this type of strategy? And for us, we did not have that. We leaned on Cardinal for a lot of those resources and strategies, as well as trying to put the right people in place. And then by deploying this, we were very successful and have been very successful over the last few years. So I'd like to extend a very sincere thank you to everyone, certainly Beckers, for allowing me the opportunity to share my journey with you. Now it's my pleasure to introduce our next speaker, Virginia Roof from Mount Carmel Health Systems. Virginia?
Thank you so much, Neil. I'm excited to tell you all a little bit about how Mount Carmel has implemented a health system retail pharmacy and our journey and the success that we've seen in our market. The Mount Carmel Health System is located in Central Ohio, and we have 4 hospitals, 4 community hospitals located mostly in the suburbs around the Columbus area. We also have freestanding emergency rooms, outpatient facilities, a rehab center, so various services that we provide in our community. And the vision within Mount Carmel is a mission-driven, innovative health organization where we will become a leader in improving the health of our community and each person that we serve. And in addition, that we will be the most trusted partner for life. And so as we thought about our strategic plan from a pharmacy services perspective, we knew that a retail pharmacy would help really partner with our patients and make sure that they had the resources that they needed to take care of themselves. So we wanted to be more proactive, and we wanted to be part of that continuum of care that reduced the barriers for med adherence and also just improve the overall care and potentially readmissions for our patients. So in 2015, we had partnered with Cardinal and decided that we wanted to build a brick-and-mortar retail pharmacy, very similar to what Neil had discussed. We thought about the location that it should be placed. We wanted it in a lobby, and we wanted it very accessible to both the patients in our hospital as well as people that may be coming to visit that storefront, so easily accessible in the lobby space. And we wanted to become even more innovative because we didn't think we needed 4 retail pharmacies to serve all 4 of our hospitals. So we decided to build one brick-and-mortar store that would support all 4 of our community hospitals. So again, I mentioned we're located around Columbus, Ohio. The closest next facility to our retail pharmacy is about 10 miles, and the furthest is about 25 miles. So we range, in distance from about, a 10 or 15-minute drive to a 25 or 30-minute drive. So that one retail pharmacy services all 4 locations, and we do that through a courier and delivering medications. So we partnered with Cardinal to not only start with the initial startup of our retail pharmacy, but also ongoing management and operation of our retail pharmacy moving forward. And then when we first started thinking about how we would implement these services, we really thought about our core values and what was our driving force, what outcome did we want to see as part of this project. And so when we thought about it, the 2 main things that came to mind were reduction in readmissions, which is a key driver for a lot of organizations. So we thought about that Medicare hospital readmission reduction program and how could we best serve those patients. And then we wanted to improve the coordination of care to support our patients that are part of our accountable care organization. So we had started down the accountable care organization road around the same time and knew that we needed a better way to support patients as they transitioned from our community into our hospitals and then back out into the community and beyond. So we wanted to make sure that we supported those patients. And as we developed the different program components, the first thing we thought about was the populations that we wanted to serve. So we wanted to serve that Medicare population. We wanted to serve patients that were at high risk for readmission or they were at high risk at discharge. They were going home on complicated new therapies. We also wanted to serve our ACO patient population. We knew we wanted to provide a charity program because part of our commitment to our community is serving the underserved and the poor, and so we wanted to make sure that our most vulnerable patients had access to medications. And then we wanted to make sure that we served our colleagues, our own employees. We wanted to make sure that they had access to medications and that we made it easier for them to get the medications that they need to take care of themselves and their families. So as part of our Meds to Beds program, I mentioned that we had this one core retail pharmacy located in the lobby of one of our hospitals. So we had to get creative about how were we going to integrate our meds-to-beds program. So we have tight integration between our retail pharmacy. We have discharge pharmacists that work on our population health team that do counseling at the bedside. And we also work with our case management team and obviously our providers. And so tight integration with them was key in making sure that we had a good meds-to-beds program where we have medication discharge orders early so that we can fill those prescriptions and then get those couriered from our retail pharmacy to the individual sites where that patient would be discharged from that day. So that hub and spoke model is really kind of the model that we chose for this meds-to-beds program, and we use a retail navigator, so it's a pharmacy technician. And the pharmacy technician, first determines if a patient would like to be included in the program, but then also delivers those medications to the patient and helps with that transaction at the bedside once delivered. We then tracked our results and wanted to see if we had an improvement in our readmission. And so with acute MI, we saw about a 48%, almost 50% reduction in readmissions for patients that had gotten their medications prior to discharge versus patients that had, foregone the meds-to-beds program. In our COPD patient population, we saw about a 40% decrease. In heart failure, a 16% decrease, and about the same in pneumonia, about a 16% decrease in hospital readmissions, 30-day readmissions. And then I thought I'd share a couple stories with you just of how this has impacted our patients, and these are common scenarios that we come across every day. The first example I'll give you, the reason the patient was admitted isn't necessarily common, but the barriers that they were presenting at discharge are very common. So there was a patient that had been admitted after being struck by a car in their driveway while going to the mailbox. And the discharge pharmacist had talked to the patient and asked if they were interested in our meds-to-beds program. The patient and the caregiver were very interested because this patient had been injured and it was going to be difficult to stop at a community retail pharmacy. So they wanted to make sure they had the medications before they left that day. So in this patient, the first thing that we noticed was that an antibiotic had been sent to a community pharmacy earlier in the patient's hospital stay. And so the navigator had talked with the patient and determined that, yes, they did in fact want to leave with that antibiotic. They didn't want to have to stop at the community pharmacy. They wanted to be able to streamline things and, walk away with what they needed. So we were able to talk to the provider, get a new order for that antibiotic and make sure that we canceled the other antibiotic order at the community pharmacy so that there wasn't any duplication. The retail navigator was also able to provide a 30-day voucher for one of the medications, Eliquis. So that saved the patient $45 on their first fill. And then while processing those medication orders, those prescriptions, we noticed that the patient had been ordered Spiriva, and we were able to coordinate with the provider to get that order changed to the Incruz Ellipta preferred brand inhaler that was the preferred product on that patient's formulary. So that would have been a barrier, as soon as they would go to pick up that inhaler at their community pharmacy, that would have been a barrier, and they would have been trying to get a hold of a hospitalist to get that order changed. And in this circumstance, we were able to remove that barrier right from the beginning. In a second example, we have a patient that was discharged home post-STEMI. And as with many of those patients, they're going home on dual antiplatelet therapy and had prescriptions for both aspirin and Brilinta. This particular patient typically got his medications filled at the VA and was concerned that with the VA's limited hours that he wouldn't be able to get there and get started on his new medications right away. So in order to avoid a potential delay or lapse in time of therapy, he wanted to make sure he had his medications filled prior to leaving. And so we were able, again, to use a voucher card to, lower the initial cost for the patient and also send a high-risk patient home with the medications that they needed and make sure that there was no lapse in therapy for that patient. And as I mentioned, we really have a promise to our community that we want to make sure that we take care of all patients, no matter their ability to pay. And so there was a charity component that we wanted to make sure was supported in the care of our patients. So one of the programs that we utilize is a medication assistance program, and that's an outpatient medication program that's available to patients with limited resources. This program is specific to Mount Carmel patients and the prescribers within selected clinics, but it allows our patients to get medications free of charge and allows them to make sure that they have the medications that they need to treat their chronic disease states. We also do some charity care for patients that are inside of our hospitals, so discharge patients that are unable to, afford the medications that are necessary for their long-term health. We're able to fill those medications through our retail pharmacy, and that's supported by our Mount Carmel Foundation. They support the payment of that and help cover those charges. And then we also utilize a program called the Dispensary of Hope. It's a nonprofit generic medication supplier, and the Dispensary of Hope and Mount Carmel partner to supply select generic medications and insulin free of charge to eligible patients. So that's a program that we're able to enroll and utilize and get medications, procure those medications at a lower cost. And then as I mentioned before, the employee component to it was, also a big driver. We wanted to be able to provide a benefit to our colleagues that would allow them to get their medications filled at their, place of employment and delivered, and it's one less stop and one less thing you have to worry about. With over 10,000 employees, we felt like that was definitely an opportunity for us and that we could help control not only, the ease and convenience for our colleagues, but that we could also help control our employee benefit cost. And so as a mom of two young kids, I have a 5-year-old and a 2-year-old at home. Convenience is key for me. That was a huge driver for me, too, is that we wanted to make things as easy as possible. So we do have what we call pickup stations available at each of our hospitals so that employees that work at the location that has our brick and mortar store can visit our retail pharmacy. But if they aren't at that location, they can still just pick up their medication at the site that they work at the care site that they provide services at. So we offer great convenience for our employees and have seen growth in our employee prescription volume. And then, when COVID hit, we had to get more creative. We had to think about, well, how are we going to change the way that we provide patients medications and our colleagues medications? So as we moved into the March and April timeframe, our retail pharmacy was able to pivot very quickly and started providing medications to our colleagues and patients at their home, but through mailing them rather than having our colleagues come to pickup stations or come to the actual retail pharmacy. So very quickly we were able to pivot and again relieve the fears, relieve some of the craziness that was going on. We were able to help our colleagues and help make sure that they still had the medications they needed and to offer that in a different format than they had been doing before. So to summarize, the 3 ingredients for success, first is to make sure that the hospital stakeholders understand the benefit of an outpatient pharmacy. I don't think we would have been as successful if we didn't have this driving force and need for coordinated care and wanting to serve those high-risk patients that are vulnerable for a hospital readmission. So we really had to understand what was important to our executive leaders from a strategic plan and make sure that our pharmacy services aligned with that. The second piece was that we needed expertise in an area that we didn't have at the time. So everyone on our team in 2015 was health system, hospital-based pharmacist. And so that's where Cardinal really came in to help provide a service that was new to us. They were a partner that understood the retail pharmacy environment and understood how to help us build that brick and mortar store and then gain traction over the course of the next several years with that service. And then we needed to work on integration because it took a lot of work to get buy-in from our providers, to coordinate the delivery of medications with the nurse at the bedside. We also needed to work with case management and other providers just to make sure that everyone was on the same page as to why this program was important, but also what type of services it can give our patients. So through that education, expertise, and then integration, we've successfully implemented this retail pharmacy program and have seen a lot of value from a care coordination perspective. So I thank you for the opportunity to share this information, and I think I'll hand the slides back to Kelly, and she'll wrap up.
Thanks, Virginia. So to bring it all together for what you've heard today and evaluating really the best operating model for your facility, I think Neil and Virginia did an outstanding job really discussing their specific operating models and areas of focus at their facilities that align with their specific strategies, and looking at reducing readmissions, improving coordination of care, reducing employee benefits costs, and even supporting charity care in the community. So with that, I'd like to transition to Becker's to facilitate the Q&A portion of our discussion. And once again, I really want to thank Neil and Virginia for sharing their experiences and their time today as well.
Thanks, Kelly. I'd also like to thank you, Neil and Dr. Roof, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we have time for. And I will jump right into the first question. And the first audience member wants to know, with the med-to-beds patients, who counsels the patients and when? Is it the discharge pharmacist, the retail pharmacist, and is it by phone or in person? And Dr. Roof or Neil, can you tackle that question?
Yes, this is Virginia. Yes, from a Mount Carmel perspective, we kind of tag team. It depends on the scenario. So we have discharge pharmacists that are just on first shift. And so while we have a discharge pharmacist in-house, we definitely try to utilize that resource first, just to give that personal touch and, direct contact with that patient. But there are instances where, someone's busy or, can't get there right at that moment. So we do utilize our retail pharmacy for backup and in instances that it just makes more sense to do it via telephone.
This is Neil. From our perspective, it is the retail pharmacist. Our pharmacy tech connects the patients with the retail pharmacist who does the counseling. And then really the unique piece over the last several months is with COVID and our COVID unit, we've utilized some telehealth and, if you will, audiovisual type connections with those patients. So that's from our perspective, that's who does that.
Awesome. Thanks for clarifying, Neil and Dr. Roof. The next question I have is, for the sites that offer employee pickup, what type of pickup platform do you use?
Yeah, so we do offer employee pickup. So we utilize a combination of things. So we utilize our retail navigators that are the same patients that are delivering to the floor. An employee can go and pick up their medications from that individual. So that's our most standard model. We also have our brick and mortar store in the lobby of one of our hospitals. So at that hospital, they pick up in the actual retail pharmacy, and we even have some extended hours that are outside of our normal patient hours to help hit some of the night shift and off-hour colleagues that we may have. And then, so we do not use a kiosk, or I know there's some different technologies out there. So we use a human being, or our inpatient pharmacies have also served as a place to go and pick those up.
And we have a very similar model. Again, our 2 outpatient pharmacies, employees can go to either one of those 2 pharmacies and pick it up traditionally. We also offer drive-through as well as curbside pickup. So just depending on the situation, just a traditional, no kiosks.
Great. Thank you both so much. The next question I have is, do you complete phone calls to patients post-discharge during the 30-day period to ensure compliance?
I'm sorry, can you repeat the beginning part of that question?
Yeah, absolutely. Do you complete the phone calls to patients post-discharge during the 30-day period to ensure compliance?
So from Mount Carmel's standpoint, we have a couple of different mechanisms. So our retail pharmacy is not always the one doing a follow-up phone call. As I mentioned, we have some integration with our population health team, and so for a lot of our patients that are utilizing our retail pharmacy services and meds to beds program, we have someone from our population health team that is following up with that patient, and we try to streamline, the various phone calls and follow-up communication that they get. So usually it's that population health person that's following up with the patient.
Great. Thanks, Dr. Roof. The next question I have is, are your outpatient pharmacies 24-hour operations? And if not, how do you deal with the after-hours discharge scenarios to offer a meds-to-bed service? And Neil, I'll have you grab this one first.
Our 2 outpatient pharmacies are not open 24/7. So the after hours for us is really connected with some of the local pharmacies. We have 1 or 2 that are open 24/7 that we have a relationship with. So that's how we address the after hours for any of our patients and or employees.
And I guess I'll mention too, from a Mount Carmel standpoint, no, we do not have after hours, and we also don't have every day of the weekend covered. And so we do utilize, just the regular pharmacies in our community if it's outside of those hours. But I will say one of the benefits of having your own retail pharmacy is that if there's a particular patient or a particular scenario that we're concerned about, these are our people, these are our patients, our colleagues, our retail pharmacy, and so we're able to do a little bit better in coordinating that. So if we have to courier something to a patient's house, or we need someone to stay a little bit later to make sure that prescription gets filled, those are the accommodations that we hope and expect that we can make with it being our own operation.
Totally. Thank you so much. The next audience question I have is, how do you enroll med to bed patients? Are they referred to by the nurse or provider, or do pharmacy staff reach out to patients? And Neil, if you can grab that one first.
Sure, thank you. Yeah, we reach out to the patient directly and have a meds to beds technician that offers that service to our patients. And then again, if they express interest in that, we connect them back to the retail pharmacy.
Thanks,
we have a
Neil.
similar
and
process.
Dr. Roof?
Yes, we have a similar process with our retail navigators, reaching out to patients, visiting them, and asking if they're interested in the services. We also have been working with our medication historians that as a patient is admitted and we are going through their medication list at the beginning of their stay to start introducing the retail pharmacy services that we offer and get them thinking about, is that something that they're interested in, and we can start that process earlier in their stay.
Thank you. So the next question I have is more broad in nature, and the audience member wants to know, what is the greatest challenge in operating a med-to-bed program?
So the biggest challenge for us was getting the provider to write the discharge orders as early as possible. It made it even more difficult when we added the courier piece of it, when we weren't going to have a retail pharmacy at every location, when we were going to have this hub and spoke model. We really needed to be proactive about what medications were going to be ordered at discharge. So they couldn't wait until the patient was 10 minutes from walking out the door. We needed to make sure that that was done, 2 hours in advance so that we'd have time to fill and courier those medications. That was probably our biggest barrier, was that early planning of the discharge medication list.
Totally. And Neil,
and for us,
what was the greatest challenge?
Yeah, for us, probably the biggest challenges were the transition from, again, an employee outpatient model to a full-blown outpatient model retail store. So making that transition, and then really the organizational awareness as it relates to that program for all the stakeholders. So just we had to be very consistent and round often, and then again have a strong marketing internal plan to keep it front and center, because it was such a new program and it just wasn't front and center initially.
Totally. So Neil and Dr. Roof, can you describe a little bit about how COVID-19 has affected the volume associated with your retail pharmacies? And Dr. Roof, if you can grab this one first.
Sure. At first, in the beginning, in the March time frame, our volumes were astronomical. We were just trying to keep up. So everyone, just like you were going to the grocery store for toilet paper, everyone was also going to their pharmacy to fill any prescriptions that they thought they might need. So we definitely saw an influx during that time frame. And then, like I mentioned, we had to completely change, the way that we delivered medications. We quickly closed our doors to visitors and, started temperature monitoring and, to get in the building. And so it made it harder for people to visit our retail pharmacy. So we had to get creative. We started mailing prescriptions, and then things that were refrigerated or couldn't be mailed, we offered curbside pickup. We had to add a second phone line in order to facilitate that curbside pickup in a timely manner. So there was a lot of pivoting that we had to do Overall, though, our volume has stayed steady. We had that colleague base, I think, really helped make sure that our volumes didn't dip too low. Our colleagues were still showing up to work every day and still needed their medications. So that helped bolster our prescription volume even when our patient volumes were different than they were before.
And for us at TJ Regional, I would say the decrease has probably been 20 to 25% for the first 2 months of COVID, again, April, May. And much like Virginia shared, it mirrored our outpatient and inpatient volumes. So in our state, initially for the first month, they closed all of our physician offices, if you will, in-person visits, as well as all of our outpatient business. So we had to be creative, curbside pickup, drive-through. We were only doing televisits physician-wise. And then on the inpatient side, our volumes dropped significantly, and it mirrored that drop from meds to beds. So it was pretty significant for the first couple of months, but in the last 2 months, it's bounced back.
Thank you both. That is so helpful to know how COVID has really kind of impacted those volumes. My next question is, do you have plans to expand your brick and mortar locations in this physical year or beyond?
From a Mount Carmel perspective, no. We have found that this model works for us. We're close enough, and I'll mention too that actually, from 2015 to present, we actually moved and built a new greenfield hospital and moved a hospital in the meantime. And so, and it moved further away. It moved from about being 15 miles away from our retail pharmacy to about 25 miles away. And that has still worked. So we have no plans for an additional brick and mortar store.
I think as it relates to the region that we work in, we're always evaluating opportunities. At this point, I would say no, nothing is in the next 6 to 12 months, because really with this point, we're still trying to optimize our operations as well as optimize our capture rate in both our outpatient pharmacies, but certainly not off the table in the future.
Thank you both so much. So my next question is for Dr. Roof. One of our audience members wanted to know if the Ohio outcomes data has been published anywhere in a peer-reviewed journal.
No, it has not been published anywhere, although there's been consideration of how else we'd like to share this information, but no, it has not been published anywhere.
Thank you for clarifying. The next question I have is for both of you. I'd love to touch on it. And it is, why do we need separate leaders to oversee the inpatient and outpatient pharmacies? Couldn't the inpatient pharmacy leader oversee both? And I'd love to have both Neil and Dr. Roof weigh in on this question.
Yeah, so in the Mount Carmel format, I guess I'd say yes and no. So I am the pharmacy leader for our health system, and all components of pharmacy report to me, whether it's inpatient or outpatient, our ambulatory services. And that's been a strategy that we think really works within our health system. As we broaden our scope and broaden the way that we take care of our patients, we wanted to make sure that we had integration of our pharmacy services. And if we were working on something in our retail pharmacy, we wanted our inpatient pharmacy to know about that, and vice versa, so that we could better coordinate and maximize our resources. So we do funnel all of our, all of our pharmacy services up through, a regional team and myself as the regional leader. But we did need expertise in how to run a retail pharmacy, because an inpatient pharmacist that has only ever worked inpatient really knows nothing about the retail pharmacy business. Prior to my involvement with the retail pharmacy, I had very little experience, had only had experience in a retail setting in college. And so this allowed for us to have expertise in how to run that business, but also integrate them as one team across our health system.
And from our side, again, we have a director that oversees the outpatient as well as acute care pharmacy operations, because I believe that you have to be very cohesive as it relates to connecting those strategies in your health system. So we do have one person that reports up to now, much like Virginia just said. I completely agree. The outpatient manager and the acute manager are two separate people, because those are really two separate set of skills and expertise and people that have passion for that type of medicine to run those organizations. And there's a lot of different regulations in both sides. So from our perspective, I believe it does take, at the management level, people that are experts at doing that specific skill. So that's the way our operation's set up.
Thank you both so much for kind of explaining that for our audience. The next question I have is, what's the growth plan for your retail pharmacy in the coming years? And Neil, I'll have you grab this one to start off with.
Yeah, that's probably the easiest question you've asked yet. The growth plan is to continue doing exactly what we're doing, trying to improve our product, continual improvement, and increase our capture rate for both those outpatient pharmacies.
And from my perspective, probably our biggest opportunity is our colleagues, building on our colleague prescription volume. That's, steady, long-term patients that will always be with us. The Meds to Beds program is great from a patient experience and is great from that care coordination perspective, but they may not come back to our retail pharmacy time and time again. If it's not convenient from their home, what if they live 30 minutes away? So the colleague base really helps sustain and allows us to be a profitable business and still offer, creative solutions for patients as they touch our health system. So definitely building on our colleague base and getting more integration from that perspective.
It's great to hear that growth and doubling down on what is working is the path forward for both of you. So we are nearing the top of the hour, and I think I can sneak in a couple more questions. This next one is, do you have any advice on how to get physicians to send prescriptions to your pharmacy rather than a major chain pharmacy? And Dr. Roof, I'll have you take this one first.
I think part of it relies on the provider, but I also think, a really integral part of that is the patient's preference. What does the patient want? If the patient tells their provider they want their medications before they leave and they want them from your facility, that's really a big driver, I think, for providers. They want to make sure the patient preference is adhered to. But, the provider is still a key person in making sure that this coordination works and that they believe in our strategy. So in convincing them of, choosing our Mount Carmel retail services, I think that they see how we can address the barriers of the patient immediately. We can determine what inhaler is their preference and make sure that the patient has what they need before they walk out the door. So I think that's been a key strategy for us, is removing the barriers that they end up having to address via phone or via being paged later, that we can address those right up front.
And then again, I think just quickly, you can't overemphasize trying to round and trying to make sure you're really quick on feedback whenever there is some issues that some of your physicians or providers express. I think the other thing, exactly what Virginia said, helping physicians and providers understand the barriers behind patients getting prescriptions in their hands, the insurance obstacles, and our goal is, again, is good patient care, so we're trying to remove all those barriers, but it's not always as easy or as efficient, therefore, in some cases, prevents patients from getting their medications. So I think just reinforcing what the barriers are and how we are trying to solve those problems.
Great, thank you so much. That is all the time that we have for today. I want to thank Kelly, Neal, and Dr. Roof for their excellent presentation, and Cardinal Health for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.